Hello everyone. Welcome back to this series of lectures in pulmonology. Today we'll be talking about pulmonary thromboembolism. So let's start. So what does this term venous thromboembolism refer to? So as we know, thrombus means clot. Okay, so thrombus means clot. So clot where? Clot in the venous system, right? So where is the clot formed exactly? So this includes the deep vein thrombosis, which is DVT, and PTE, which is your pulmonary thromboembolism. So due to certain predisposing conditions, what are those conditions that we will be looking at? There can be clots which are formed within the venous system, predominantly the deep veins. Okay, the deep veins of the calf, the deep veins of the lower limbs, or sometimes even the upper limbs, and these can embolize and get lodged within the pulmonary vasculature, and this is what we call as the pulmonary thromboembolism. Okay, so this pulmonary thromboembolism and DVT together are grouped as venous thromboembolism disorders. Fine. So let us understand the pathophysiology. What is the reason behind which a clot is formed within the pulmonary vasculature? So let us understand the risk factors first. So many times any acute illness can result in a prothrombotic state. So any acute illness can result in a prothrombotic state because of dehydration or prolonged bed rest, as a result of which there is a tendency of formation of clots within the deep venous system. Then other comorbidities including, very importantly, malignancies. Malignancies induce a prothrombotic state in our body and it can predispose to the formation of deep vein thrombosis. Then OC pill use. OCs are oral contraceptive pill use, especially in ladies. Then other systemic conditions like CKD, COPD, heart failure. Alright, and diarrhea and a bedridden state, very important. So these are some of the most common risk factors for the development of the clot within the venous system. Okay, so apart from this, very important, especially the modern life, is a long haul travel, long haul air travel. Long haul air travel where you're sitting for a long time or maybe you're not well hydrated. This can promote stasis within the venous system and result in the formation of clots. Okay, so always remember acute illness, prolonged bed rest, long haul air travel, cancers, OC pill use, bedridden states, and other systemic conditions like CKD or COPD or heart failure. All of this can predispose to the formation of your venous thromboembolism. Okay, fine. So these are some of the known risk factors. Apart from this, certain genetic predisposing factors can also be present, which includes prothrombotic states such as autosomal dominant conditions where there is a factor V or Leiden factor mutation. Factor V or Leiden factor mutation, this is the most common inherited cause. This is the most common inherited cause for your venous thromboembolism. Then prothrombin gene mutation. These are all agents which prevent the clotting of blood, right? So mutations in these genes can result in unnecessary, unwanted clotting of blood. Then very important, your antiphospholipid antibody syndrome or your APLA syndrome is another important factor that predisposes to the formation of clots. Okay, fine. Now let us understand what are the underlying pathophysiological process which is responsible for the formation of these clots. So the first and the most important is that VTE is associated with a background of inflammation. It is associated with a background of unchecked inflammation. Second, there can be activation of platelets, and these platelet microparticles then cause stimulation of neutrophils. So unwanted or excessive activation of platelets results in the formation of platelet microparticles which stimulate the neutrophils. The neutrophils then begin to release substances that form what is called as the neutrophil extracellular trap. We have heard of this term in pathology. NET stands for neutrophil extracellular traps. These neutrophil extracellular traps are in turn responsible for excessive unchecked thrombin generation, which is a procoagulant which is responsible for the clotting of blood. So in the background of inflammation, there can be excessive activation of platelets, which results in the production of platelet microfracticles, neutrophil extracellular traps, and excessive activation of thrombin. Okay, so this results in what we call as your famous Virchow's Triad, right? So there is a predisposing factor which results in venous stasis. So whenever there is a blood flow, the blood has to flow continuously. So whenever there is a stasis of blood, there is a block to the movement of blood, then what happens? There is pooling of blood, right? There is pooling of blood or there is stasis of blood. This venous stasis in the background of inflammation results in hypercoagulability. There is more procoagulant factors within the blood, and this also promotes some amount of endothelial injury. We have heard this in pathology. This Virchow's triad comprising of venous stasis, hypercoagulability and endothelial injury on the whole results in the formation of a thrombus. Okay, clear? So this is about the pathophysiological processes which are happening in your venous thromboembolism. Now, once there is a venous thromboembolism, most often from your deep venous system, it can get dislodged and go and occupies itself in your pulmonary vasculature. So once it gets occupied in the pulmonary vasculature, what happens to the lungs per se? So what is the pathophysiology of the manifestations in your pulmonary thromboembolism, which is in your lungs? So first, there is a sudden cutoff to the blood supply in the lung. The pulmonary vasculature are blocked, so there will be hypoxemia. Yes, this is understandable. There is going to be hypoxemia. There is going to be an increase in the alveolar arterial oxygen gradient. Okay, so the gradient is going to increase because of this hypoxemia. Then, there are some parts of the lung which are going to be ventilated, but they are not going to be perfused well because of this pulmonary thromboembolism. So this results in a ventilation perfusion mismatch. This results in a ventilation perfusion mismatch, and there is going to be an increase in the anatomic as well as the physiologic dead space. Okay, so there is going to be an increase in the anatomic and physiologic dead space. So there are going to be many areas which are not properly ventilated or perfused. Okay, fine. Then when there is a block to the flow, what is going to happen to the resistance to the flow of blood? There is going to be increased pulmonary vascular resistance. Okay, so if you just go back and look into the chapter on pulmonary artery hypertension, we have learnt that your WHO class 4, which is chronic thromboembolic pulmonary hypertension. Why does that happen? This happens because of a chronic pulmonary thromboembolism, and this is the reason. So whenever there is a chronic pulmonary thromboembolism, the resistance can increase. The resistance to the flow of blood is increased, and hence you can have increased pulmonary pressures. Okay. Apart from that, there can be an impaired gas exchange. Like I said, ventilation perfusion mismatch. There will be alveolar hyperventilation and the compliance of the lung decreases. So these are the various pathophysiological hallmarks of pulmonary thromboembolism. So whenever we speak about the pathophysiology of PTE, always remember the various risk factors. Whenever you see a patient with PTE, never forget to ask about your long haul travel or your OC pill use. Okay? And remember Virchow's triad. Fine. Okay. Now, once there is a pulmonary thromboembolism, what are the other changes that happen? Which chamber of the heart is most affected? Okay. So, we know that when you look at the heart, this is the RA, RV, LA and LV. Right, arising from the RV is your pulmonary artery. This then goes to the lungs, correct? Then you have the pulmonary vein which drains into the LV. So this is very clear, correct? So whenever you have a thromboembolism or a block in your pulmonary vasculature, predominantly your pulmonary arteries, so which side of the heart is going to get affected most? It is obviously your RV and your RA. So the first chamber which will be affected is going to be your right ventricle. So whenever there is a pulmonary thromboembolism, what happens to the resistance within the pulmonary artery? the resistance is going to increase. So there is going to be an increase in the resistance. Now, if the resistance is going to get increased, what is in turn going to get increased? It is going to be an increase in the afterload to the RV, right? So the RV has to pump against a higher resistance. This is what you mean by afterload. So increased afterload is going to be resulting in what? An RV pressure overload. So this, I hope, is very, very clear. So there is going to be an pressure overload in the RV, right? So this is very similar to your systemic hypertension. In systemic hypertension, there is going to be an increase in the peripheral vascular resistance. Which chamber is going to get affected? It is your LV, right? So your LV is going to pump against a higher afterload, correct? So similarly here, your RV is going to pump against a higher afterload. So there is going to be an RV pressure overload, and over the course of time, there can be RV dysfunction. If there is a massive pulmonary embolism, there can be an acute RV dysfunction. Okay, so amongst the first manifestations will be an RV dysfunction and RV failure. Okay, now what happens as a result of this RV dysfunction? Now, RV dysfunction can also result in decrease to the LV preload, correct? So, if your RV is not pumping out blood enough, then your LV remains underfilled. Your LV and LA remains underfilled. So, there is going to be a decrease in the preload to the LV, decrease in the LV cardiac output, and ultimately it is going to result in a decrease in the blood pressure. So, this is the reason why a massive pulmonary embolism presents with hypotension. A massive pulmonary embolism presents with hypotension because the RV dysfunction results in a decrease in the LV preload, and the LV cardiac output ultimately reduces. Okay. Also, an increase in the RV wall tension is going to cause decrease in the coronary perfusion as well. Okay. Fine. So, this is about the various pathophysiological changes and how the heart is affected during a pulmonary embolism. So, coming to the classification of PTE. It can be classified as massive, submassive and a low risk PTE. Okay. So, a massive pulmonary embolism is basically defined as when more than 50% of the pulmonary vasculature is blocked by the pulmonary thrombus. Okay. And the most important clinical feature of a massive pulmonary embolism is that they present with hypotension. So, they present with hypotension and a blood pressure less than 80 systolic. And they present with acute onset breathlessness. Okay. So, acute onset breathlessness and hypotension, the patient actually collapses and can also go into cardiac arrest, where the pulmonary vasculature, more than 50% of it is blocked. This is your massive pulmonary embolism. So, what is a submassive condition? Here you have RV dysfunction, but the blood pressure is normal. So, always remember there is normal blood pressure, but the RV dysfunction is present. Okay. So, there is a pulmonary embolism resulting in RV dysfunction, but it is not huge enough to cause a decrease in the LV cardiac output, and hence the blood pressure is maintained. Okay. So, submassive is basically the most common type. Submassive pulmonary embolism is the most common type. Low risk PTE is when you have only about 10 to 20% of the vasculature is affected, and it can basically present in the form of prolonged hypoxemia. For example, a viral pneumonia patient who has been admitted for more than 10 days, he has been bed bound and his hypoxia is not improving. So, you may have to suspect a pulmonary embolism that time, and you do a imaging and you find that there is a PTE. So, here the patient is most often hemodynamically stable. They just present with periods of prolonged hypoxia. Okay. So, this is about the classification. We have massive, submassive and your low risk PTE. Your submassive is your intermediate risk PTE and your massive is your high risk PTE. Fine. So always remember, your massive pulmonary thromboembolism presents with acute onset breathlessness and severe hypotension, and they can also go into cardiac arrest. Let us look at the clinical features. So like I mentioned, low risk PTE usually presents with prolonged hypoxia. They usually present with prolonged hypoxia and minimal breathlessness. Okay. Massive PTE on the other hand presents with hypotension, acute severe breathlessness, hypotension, acute severe breathlessness and severe RA-RV dysfunction. Okay, clear. Now let us look at what are the various means by which we can diagnose a pulmonary thromboembolism. Okay, so first we will look at the blood test. So first which we use is your D-dimer. Okay, so D-dimer is basically a breakdown product in your coagulation pathway, and this D-dimers usually have a age adjusted cutoff. So normally we take values more than 500 is considered to be elevated D-dimers. Okay, but if you look at elderly individuals, maybe of 70 to 80 years of age, their normal values itself have a higher cutoff. So if you look at the age adjusted D-dimer, we take age into 10 as the cutoff. So for a 70-year-old man, the cutoff will be around 700. Okay, so what is the use of D-dimer in the diagnosis of PTE? So the most important use is that it helps in ruling out PTE if it is negative. That means that if there is a positive D-dimer, it does not always mean that there is a pulmonary embolism. But if the D-dimer is negative, then we know for definitely that the PTE is a less likely possibility. Okay, so it helps in ruling out PTE, especially if it is negative. So it has a negative predictive value. So it's very, very useful because of its negative predictive value. So for example, I'll explain this with a clinical scenario. So if there is a patient with pneumonia who has been hospitalized for a long time and he is having persistent hypoxia which is not improving, then you do a D-dimer. If a D-dimer is negative, then we know that his hypoxia is predominantly due to the underlying disease process and that has to come under control. But if his D-dimer is positive, right, then we cannot clearly say that whether this is because of a pulmonary embolism or is it because of the underlying disease process itself. So in these cases, you may have to scan further and then decide whether a PTE is present or not. Okay, but if it is negative, for sure we can say that it is because of its underlying process and it is not because of PTE. So it helps because of its negative predictive value. Okay, fine. So the next thing that we look at is what we call as a clinical prediction rule, which is your modified Wells criteria. So as per this modified Wells criteria, we have certain clinical conditions which are given a particular score, and based on the total score, we decide whether a PTE is less likely or more likely. Okay, so a low clinical probability. A low probability is when the score is between 0 or less than 0. Okay, then a moderate probability of having a PTE is when the score is between 1 to 2, and a high probability of having a PTE is when the total score is greater than equal to 3. Okay, so what are the components of this modified Wells score? So active cancer is given a score of 1, paralysis, paresis or recent cast, a recent surgery, or if the patient has been immobile, then this is given a score of 1. Bedridden for more than 3 days or a major surgery in the past 12 weeks is given a score of 1. Tenderness along the distribution of the deep veins. So tenderness is also another very, very important clinical finding, especially for a deep vein thrombosis. So this is given a score of 1. Entire leg swelling is given a score of 1. Unilateral calf edema more than 3 cm. So all these 3 points are especially in favor of a deep vein thrombosis. Whenever you examine a bedridden patient, please do look at the bed end of the patient, look at the limbs. So if one limb is more swollen, more tender than the other limb, that means that there is a DVT, and this DVT can in turn predispose to the formation of a PTE. Presence of pitting edema, score of 1, collateral superficial non-varicose veins, score of 1, and alternative diagnosis less likely, it is a score of -2. So depending upon the total score, if the score is 0 or less than 0, it is a low probability, 1 to 2 is a moderate probability, and more than 3 is a high probability. So this is your modified Wells score, which is a probability score for PTE. Fine. Then, what are the other investigations that you can do in your corroboratory diagnosis of PTE? So, what are the ECG changes? The most common ECG change, the most common ECG finding in a PTE is sinus tachycardia. Okay, so the most common ECG finding in a case of pulmonary thromboembolism is sinus tachycardia. Then another very important pattern which often suggests a PTE is called as the S1QT T3 pattern. Okay, so let us look at this ECG. Can you see that there are deep S waves in lead 1? Okay, then you can see that in lead 3 usually they never find Q waves. So there are Q waves in lead 3 with T inversions in lead 3. So this is what we call as the S1Q3 T3 pattern on the ECG, and if it is present, it is highly suggestive of a pulmonary thromboembolism, but it is always not present in all patients, and hence if it is present, it is more likely in favor of a PTE. So always remember, deep S waves in lead 1, presence of Q waves in lead 3 and T wave inversions in lead 3 is more likely suggestive of a pulmonary thromboembolism. Okay, but the most common ECG finding is sinus tachycardia. Okay, then what are the other ECG findings that you can find? We know that which chamber of the heart is most commonly affected in PTE? It is the right chambers. So you will find evidence of RV strain on the ECG. So how do you look for RV strain on the ECG? You can have right axis deviation. So how do you look for right axis deviation on the ECG? So you look at the leads 1 and AVF. Of course, in this ECG you are not finding, but if the QRS complexes in lead 1 and lead AVF, in lead 1 it is negative and in lead AVF it is positive, it means that it is a right axis deviation. And how do you look for RV strain? In the septal leads V1 and V3, you find tall R waves with ST segment depression, T wave inversions in lead V1 and V3. Okay, so this is your RV strain. So these are the various ECG findings that you can find in pulmonary thromboembolism. Then, what is the role of cardiac biomarkers? The cardiac biomarkers that we will be looking at are TROP-I and NT-proBNP. Okay, so TROP-I and NT-proBNP are the two cardiac biomarkers that we will be looking at. So what is the role of these biomarkers in your PTE? These biomarkers will definitely be elevated. Why? Because there is damage to your RV. So there will be RV strain, there will be RV dysfunction, and RV failure can result in elevated TROP-I, elevated NT-proBNP. So always remember that elevated troponin does not always mean myocardial infarction. So what is the role here? Yes, they will be elevated, but very, very importantly, they can be a prognostic marker. They can be a prognostic marker. Okay, fine. So this is about the ECG and cardiac biomarkers. Then let us look at the imaging. So what are the imaging findings? So very, very importantly, whenever you have a patient with pulmonary thromboembolism, you will have to do a venous ultrasound, an ultrasound which is basically a Doppler of the lower limbs, predominantly looking at the deep venous system. Why? Because most often the clots are lodged in the deep venous system, and it's only from there that they embolize to the pulmonary vasculature. Okay, so how does this ultrasound look? So whenever you put a probe and you do a Doppler study, this is how the common femoral vein and common femoral artery. Look at the femoral region whenever you do the ultrasound. So, when you put a probe over here, how do you differentiate the artery from the vein? The artery is smaller in diameter and the artery will appear pulsatile, and the common femoral vein is usually compressible. So whenever you put pressure and you put a probe here, the artery remains like this, the vein becomes like this. Because of the pressure, it gets compressed, and this is what we call as the winking sign. This is what we look for when you do an ultrasound. You look for the winking. Okay, so if this winking is present, then there is no DVT. But if there is a DVT, you find that there is loss of compressibility. There is loss of compressibility, and you can also find some echogenic contents within. Okay, so this is how you use an ultrasound to find a deep venous thrombosis in your scan. Now, what are the imaging findings for pulmonary thromboembolism per se? So let us look at the X-ray findings. So these are some of the named signs that you should be aware of when it comes to PTE. So can you see in this image, there is a peripheral wedge-shaped opacity. This is what we call as the Hampton's hump. So a peripheral wedge-shaped opacity. Peripheral wedge-shaped opacity in PTE is called as the Hampton's hump. Then next sign is your Westermarck's sign. Can you see that this part of the lung is much more blacker when compared to the other side, right? So this is what we call as your peripheral oligemia. Because of a cutoff to the blood supply to that portion of the lung, there is peripheral oligemia, and this is what we call as the Westermarck's sign. Then what is the Palas sign? There is a dilated pulmonary vasculature, which is more prominently seen on the X-ray, and this is what we call as the Palas sign. So this is Hampton's hump, Westermarck's sign and Palas sign, which are certain named signs on the X-ray of pulmonary thromboembolism. Then next investigation is your echo. So what will you find on the echocardiography? You will find evidence of RA and RV dysfunction. You will find that RA and RV will be dilated. You will find evidence of RA-RV dilatation and RA-RV dysfunction. Another very important sign on the echo that we should be aware of is something called as McConnell sign. Okay, McConnell sign. So if you see the echo of a PTE patient, you will find that the LV and the apex is hyperkinetic. The apex and the LV is hyperkinetic, whereas the free wall of the RV is hypokinetic. Okay, so let me demonstrate it to you in this way. So if this is your R wave, this side, whenever you look at the echo, this is the RA, this is the RV. So apex is tethered to the LV. We know that there is RV dysfunction in PTE. So the LV and the apex of the RV are tethered to one another, and the LV becomes hypercontractile. But there is RV dysfunction. So the mid wall of the RV is hypocontractile, whereas the apex and the LV are hypercontractile, and this is clearly seen on the echo, and this is what we call as the McConnell's sign. So this is another important named sign on the echo of a PTE. Then the investigation of choice for completely confirming the presence of pulmonary thromboembolism is your CT pulmonary angiography, where there is a contrast enhanced CT that is done, and it is an angiography where there is a non-invasive imaging of the pulmonary vasculature, and you can see that there will be a loss of the contrast uptake. Can you see here? I will highlight it for you. So here there is a loss of the uptake. This is your pulmonary vasculature or your pulmonary artery, right? So this is showing you that there is a definitive pulmonary thromboembolism. In a massive PTE, you can find that the thrombus is present throughout. It will be something like this. Okay. So you can find that the thrombus is present throughout the pulmonary artery in a massive thromboembolism, and this is what we call as the saddle thrombus. Okay, so a massive embolism is called as a saddle thrombus that you see on your CTPA. Apart from this, you can also do a ventilation perfusion scan where there will be decreased perfusion. Okay, so CTPA, for it to be done, you need to have a normal serum creatinine value because you're injecting a contrast which can worsen the kidney function. So in patients where you cannot really do a CT pulmonary angiography, you can go ahead and do a VQ scan. Fine. So that is about the various diagnostic features which you can use for your diagnosis of PTE. Now let us move on to the treatment. So this is again your risk stratification. We had just looked into it. So always do a modified Wells score. Prior to your treatment of PTE. Apart from that, we also have something called as the PE score. The PE score was your traditional Wells score. So here, what are the clinical criteria that we take? We take signs and symptoms of DVT, which is given a score of 3. Alternative diagnosis less likely, given a score of 3. Heart rate more than 100, 1.5. Immobilization more than 3 days, score of 1.5. Prior history of DVT, score of 1.5. Hemoptysis, score of 1. Cancer, score of 1. Okay, so this score is now what modified, and it has become into the modified Wells score where everything is scored 1 itself. Alright, so the cornerstone management of pulmonary thromboembolism basically involves anticoagulation, right? So wherever there is a clot, you have to break that clot, right? So we have learned this in myocardial infarction as well. So similarly, the cornerstone of management in PTE is anticoagulation. Okay, so this can include warfarin based therapy and non-warfarin based therapy. So when it comes to non-warfarin based anticoagulation, the most common that we use is unfractionated heparin. Okay, so unfractionated heparin is what we use, and we give it as a bolus followed by continuous infusion, and this is IV heparin. Okay, IV heparin is given to achieve an APTT target of 2 to 3. So you maintain that the APTT between 2 to 3 times and you give IV heparin. But IV heparin is slightly difficult to monitor and it has higher risk of bleeding, and hence now we use enoxaparin or your low molecular weight heparin, which is given at a dose of 1 mg per kg per day twice daily. If you give it single dose, it is basically used as a prophylactic heparin. If you give it as a twice daily dose, then it is given for treatment, and it is given when patients have a normal renal function, right? Or you may have to give a renal adjusted dose if the creatinine is deranged. So this is given, for example, most commonly as 0.6 ml subcutaneous morning and night. Okay, so that is your LMWH. Apart from that, oral agents can also be used. So we have direct thrombin inhibitors like argatroban or bivalirudin. Then we have your novel oral anticoagulants, NOACs. Okay, so which are the NOACs which can be used in PTE? We have rivaroxaban, which is given 15 mg twice daily for 3 weeks followed by 20 mg once daily. Then we can give apixaban, which is given 10 mg twice daily for 1 week followed by 5 mg twice daily thereafter. Then we have dabigatran. For dabigatran, we need to give 5 days of unfractionated heparin and then only start your dabigatran 150 mg BD. Okay, so dabigatran cannot be given upfront, unlike rivaroxaban and apixaban are more favorable, and apixaban especially can be used in elderly. Dabigatran requires 5 days of unfractionated heparin treatment prior to initiation. Okay. Apart from this, you can also use warfarin. The thing about warfarin is that you will have to monitor the INR frequently, and it has a lot of drug-drug interactions. Okay. And warfarin again requires 5 days of administration to achieve its effectiveness as monotherapy. So even warfarin you have to overlap with LMWH. You give LMWH for 5 days and then you give warfarin up to a point where you reach an INR of about 2 to 3. So INR target here is 2 to 3. Okay, fine. So this is about the various anticoagulants which can be used in the management of PTE. The question now arises, how long you want to treat these patients? So previously we used to have this concept of provoked versus unprovoked PTE. Provoked versus unprovoked PTE means what? Provoked means there was an underlying reason for which this PTE could have happened. For example, maybe there was an underlying pneumonia, maybe there was an underlying OC pill use or a malignancy. So in these kind of patients, you give it for a period of about 6 months to 1 year, and then you can safely stop the anticoagulation. But when the PTE was probably due to genetic conditions like a Leiden factor mutation, then there is a chance of recurrent pulmonary embolism, and this cases of unprovoked PTE, they have not had a long haul air travel, they have not had any OC pill use, then these kind of patients where clear reason is not known, they might require lifelong treatment. They might require lifelong treatment to prevent future episodes of pulmonary embolism. Okay, now let us understand the management of massive pulmonary embolism. So, when it comes to the management of massive pulmonary embolism, the patient is going to be in hypotension, patient is going to be extremely breathless, and he is going to be a very, very sick patient. So, the first step is definitely volume replacement by IV fluids, 0.9% sodium chloride. You give them a bolus dose and you continue it at rate so that they remain volume depleted. And the most important step here would be you will have to take them up for an urgent fibrinolytic therapy. Okay, and the drug of choice for fibrinolysis, similar to how we use fibrinolysis in your acute stroke or in your acute MI, you have to give tissue plasminogen activator 100 mg over 2 hours. Okay, so this fibrinolytic therapy, prior to this, similar to how we have a checklist prior to MI or prior to stroke, here also it has to be followed. So there are certain definite contraindications for fibrinolytic therapy, for example, a concomitant hemorrhagic stroke or a bleeding diastasis, uncontrolled hypertension. So these kind of checklists have to be followed before administration of a fibrinolytic agent. Okay, fine. So these patients are very, very sick, and hence you have to act very quickly and the patients have to undergo fibrinolysis. But if there has been no improvement, not always did the clot lyse completely. So in these cases, you may have to go ahead for a pharmacomechanical catheter directed therapy. So in this, you may have to do a embolectomy. Okay, you can do an embolectomy, or you can also do a catheter directed therapy where through a catheter you reach the clot and then you try and inject the fibrinolytic into the vessel and try to lyse the clot. Okay, so these are the two ways in which you can further have a invasive therapy for pulmonary embolism. Okay, fine. So with this, we have come to the end of our chapter on pulmonary thromboembolism. Thank you.